Committee of after recess. Welcome everyone. Welcome to our regular meeting of the Health, Mental Health, and Education Committee. It is 9:05 and we are in City Hall, room 1010. We have a quorum. Thank you. Thank you, colleagues. So I'd like to call this meeting in order. I want to start with public comment. I have one public comment card. Wayne. 2 minutes.
Actually, the first committee meeting was yesterday. Budget and Finance met on Monday. They got you by 1 day. So, where is Mitchell Englander? Where is that little dwarf, Mitchell Englander? Yesterday, we had one of the most important Budget and Finance Committee meetings yesterday, involving two gentlemen jailed for 24 years and 34 years of their lives because of illegal arrests and evidence falsification by LAPD and witnesses. Where is that little reserve officer, Mitchell Englander, to talk about the budget and the settlement on these issues? He never shows up. So why are we paying Mitchell Englander to run for the Board of Supervisors? Why is this guy being allowed to be a councilman? He's abandoned his district. He's abandoned his job as a city councilman. So we're essentially paying him for taxpayer dollars to run for Mike Antonovich's open seat. So you should suspend Mitchell Englander from further committee activity, take him off this panel, take him off Budget and Finance, and replace him with another member of the council who wishes to still be a member of the council. Now, Felipe Funes isn't here, but he's probably stuck in traffic on the freeway because it's very hard to get here from the San Fernando Valley. So with that, we had a health commission meeting last night, and they wanted to talk about attending meetings for the LA County, and item 1 will certainly be something to talk about there. But it seems that in the Board of Supervisors, Sheila Kuehl was calling people by the F word and all kinds of slanderous remarks. So I would say that for LA County, we got to watch them. Thank you.
I'd like to move, item number 1, Mr. CLA. Could you read item number 1, please?
Item number 1 is motion Rue Weezar relative to a request from the Los Angeles County Sheriff's Department and the Los Angeles County Department of Mental Health to report on the implementation of the county jail system consent decree within the city of Los Angeles and its impact on the mental health system. This matter has also been referred to the Public Safety Committee.
Great. Can we have representatives from the Sheriff's Department and the Mental Health Department? I want to really, how are you? Hey, Flora, how are you? Really want to thank you guys for coming today. Mental health and the links between the mental health issues, homelessness, jail systems. I know we're talking about this. This is one of the prime topics of the day. And this is number 1 in the public's attention. It's important that the city and the county forge a strong relationship on these issues. And it's very exciting as a former board deputy along with Flora, seeing all the collaborations between the city and the county, amongst the city family, amongst the county family, and everything that's going on. It is a very exciting time. And I think we could only grow stronger and go forward on this issue. But to start, I would appreciate if the committee, if you could first give us an overview of the jail system consent decree, and in particular, how the decisions by the Board of Supervisors is affecting the beds for mentally ill patients in the jails. If you could introduce yourself, and I know I really want to have time for Q&A, so maybe if you guys could limit it to 10, 15 minutes at most.
Sure. Good morning, Mr. Chair, members of the board. Thank you for inviting us today. I'm Terry McDonald, I'm the Assistant Sheriff, Los Angeles County. I'm over the jails, and let me allow my colleagues from DMH to introduce themselves, then we'll start.
Good morning. I'm Kathy Warner. I'm the Deputy Director in Mental Health for the Adult System of Care.
Good morning. I'm Flora Gill-Krisaloff, and I'm with the Department of Mental Health, and I'm the Chief of Countywide Justice Planning and Development. And prior, I was a Deputy on Homelessness and Mental Health to Supervisor Zev Yaroslavsky.
Neil Ortego, the Interim Chief Psychiatrist for Jail Mental Health.
Good morning. So hopefully you're all aware of the fact that the Los Angeles County Jail System, Twin Towers, runs the largest mental health facility in the United States. We're the largest jail system in America, and we're actually larger than the next two largest jail systems combined, Cook County Jail in Chicago and Rikers Island. If you combine the two of those facilities, they don't reach the size of our facilities. We've been in oversight from the Department of Justice relative to mental health care in the jail since 1997. So it's really not a new approach, and it's an area in which correction system across America struggle with. Us particularly. Dr. Ortego will talk in a little bit about the how acutely mentally ill the people are entering our system, many of them pre-trial, trying to get through the criminal justice system. So DOJ, initially, we've been under a memorandum of understanding with DOJ since 97. In 2013, a couple of things were going on. I think people were well aware of allegations of prisoner abuse within the Los Angeles County Jail System going back to around 2011. The Department of Justice was inside of the jails looking at issues of abuse of prisoners, and at the time taking a renewed look at mental health care in the jail. In 2013, we had a series of very tragic and unfortunate suicides that really raised the issue about mental health care in the jails and the pressure in which the providers were under. In 2013, 2014, we began a very intense dialogue with DOJ in how to improve mental health conditions and treatment within the facilities. We entered into an agreement, and it's an agreement between DOJ, the Sheriff's Department, and the Board of Supervisors to improve virtually every aspect of health care within the jail, from how we do intake screening to how we do reentry. So from intake to release, virtually every aspect is under reform. The Board of Supervisors was incredible in providing resources to improve services, getting inmates out of their cell. One of the problems was we didn't have enough staff to get inmates out of their cell for treatment. DMH didn't have enough clinicians to provide treatment. We didn't have enough staff to do security checks to make sure the inmates were okay. So the settlement agreement has 60-some-odd provisions, primarily around treatment, around assessment, around reentry, security checks. That's kind of a governing principle behind it. I suspect we will be under this consent decree until Men's Central Jail is demolished and replaced with the Correctional Treatment Center. Because Men's Central Jail is no place in which to do long-term confinement. It's a facility in which the design of it is depressive. There's no ambient lighting. It's linear design, so it's hard for the staff to monitor the inmates. And it's just seen its better day. We're very grateful that the board's authorized the replacement of the facility with a very sophisticated approach of correctional treatment, but it is expensive. That facility will be the largest correctional treatment center in the United States, built in downtown LA, which is a very expensive approach, but it is the right approach. A holistic approach towards the offender, because Dr. Ortego is trying to do treatment, and there's really no place to do it within the jails where his clinicians can have some privacy. That's overarching. I'm going to pass it over to my partners, and then we'd like to give you more time to ask questions than speak. So I'll pass it over to Dr. Ortego, and then we can go from there.
Okay. Good morning, and thanks for the opportunity. I've been with the jails for about 18 years, so I've seen the evolution with the initial DOJ, and now we've kind of gone into warp drive with the settlement agreement. The settlement agreement are the things that we have kind of implemented, or we're starting to implement, as we did an initial review and revision of all of our policies and procedures. That's nearing the completion phase as we speak. We have looked at the way we provide care from the inmate reception center, the housing areas, the levels of housing, the treatment that is given, and the linkage to the community. One of the overall driving forces or principles that we're using is we've gone from, when I first started years back, to an institution that was basically warehousing people, and you had medical services, mental health, and custody, each doing their own little thing, to a much more collaborative. And I know we use the word a lot, and we say this multidisciplinary treatment, but it's actually getting there, probably for the first time in its history. We still have major deficiencies in staffing from the recent staffing assessment. Health Services brought in Dr. Tim Belovich from the state. He was the director of state hospitals, and he's spent the last 10 weeks doing a critical assessment. So we're in the process of finalizing that, and there will be a need for more staff to meet the settlement agreement. Jail linkage is a big.
I'm sorry. There's just some chatter in the back. Can you take the conversation outside, please? Thank you so much. Continue.
Jail linkage is a huge part of what we're doing. We're also short on staffing, and I'm sure Flora will comment on that. The misdemeanor and incompetent stand trial, there are many programs, but that's one that has been in place for a while. And I'd say over the last 5 years, it's gone from about 40 to the current, I think it's close to 180 patients. And there are deficiencies in the community that do limit getting those people out of the jail, and there are also deficiencies as far as staffing and resources within the jail. The physical plant, as Terry was saying, is a huge, huge obstacle to overcome. The settlement agreement has mandated that we do a lot of things, and to do them within that physical setting with the large numbers is, I want to say impossible because we'll have to do it, but it really requires a concerted, innovative, thinking outside the box approach to get these things done. Thank you.
So I head up the mental health jail linkage and mental health court linkage program. So within the consent decree, there is an item for reentry planning and reduction of recidivism, really transitioning these people back out into the community and keeping them from cycling in and out of the jail, the mentally ill. And many of them are also your homeless individuals as well. So we have a mental health linkage team in the jail. And what we're trying to do is really integrate more closely the care with health services, with substance abuse services, because a lot of times these individuals really, they may be mentally ill, but they also suffer from substance use issues, which really is the most challenging part of getting them back into the community and, you know, being able to sustain themselves and stay out of trouble out in the community. So at this point, the consent decree really puts a lot of emphasis on, you know, doing as much reentry planning as possible for the entire jail population. And as Neil was saying, that's one of our challenges, is to get more and more staffing to do that. But we do have a good program there. But the Department of Mental Health, because there is a change in the structuring of the health services at the jail, so you may already know this, but the Department of Mental Health is going to be transitioning out of the jail, and Department of Health Services will be taking over mental health substance abuse in the jail. So for us as mental health, we will still work very closely with the jail health services, because it's that transition out in the community. We want to make sure that the individuals, as they get back out in the community, you know, are in treatment and transitioning back in a healthy way. And so I'm going to pass the baton over to Kathy, because she can tell you about some of the actual community programs.
Sure. Good morning. It's a pleasure to be here. Thank you. I don't know if I'm preaching to the choir, so I'll move quickly through the opportunities that have really come forward since 2004 and the implementation of the Mental Health Services Act. And as you know, that brought forward money specifically for mental health and allowed us to really establish what we call our Cadillac program, or I call it that, which is our full-service partnership program in Los Angeles County. We have that program for all age groups. I'm the deputy for adults. I think you're primarily interested in adult populations, which are really people 18 and older, who have to have serious persistent mental illness and also have to have some functional impairments. They may be homeless, they may be individuals who go in and out of the jail setting, in and out of hospital settings. So over the last almost, I guess it's been 10 years, we've been implementing this program in Los Angeles. We have focal populations that we address, and we also have criteria that make someone eligible for a full-service partnership program. For example, we look at individuals who have had involuntary hospitalizations, a pattern of those. We look for people who may have been homeless in the last year, 120 days. Those are some of the criteria that were established early on for entrance into this program. We have 2 or more incarcerations or 30 days in the last 12 months for individuals who have been in the jail system. And that has made them eligible to be sent as a referral from jail into our programs. In Los Angeles County, we have navigation teams, one for each service area, and those navigation teams take these referrals. They can be coming from jail, they can be coming from the community, and we identify a program that will engage the inmate in the jail setting and try to, it's a voluntary program, encourage their participation upon release into full service partnership. That referral process results in an engagement period, but we try to go in and see that client in the jail system within 24 to 48 hours to begin that relationship. So it's really essential that we do that. And then hopefully they agree to services. We identify a provider in the community to work with them. This program is a multidisciplinary team approach. It's available to the consumer 24/7, 24 hours a day, 7 days a week. If they have a crisis in the middle of the night, the team will respond. The team has the ability to do a mental health assessment to determine if or when that client needs a higher level of care and to expedite that care into a hospital setting or whatever will best attend to their needs at that time. We also have what are called beyond the service dollars provided, which were allocated traditionally at $16,000 per client per year. In that dollar amount, we have what are called flex funds. Those funds have been invaluable to us because they allow us to provide housing for consumers, immediate access to whatever their needs are. Maybe they need furniture for their new apartment. Maybe they need us to pay the first and last month's rent. So that has really assisted us. I looked at some data for fiscal year 13-14. During that fiscal year, we provided FSP, the top-level program, as well as field-capable clinical services, which is also a wraparound program, to some 33,000 clients here in Los Angeles County, spent close to $250 million on that program. Recently, we've been excited about the opportunity to expand our FSP, full-service partnership, more to our forensic FSP populations. So you're going to be seeing right now, I'm working on a solicitation process that will increase capacity across the system of care for providers who will be working more than they have historically with some of our clients most at risk, those in jail settings. So we hope to augment. We have about 6,000 full-service partnership slots in the county that we've evolved over the last decade, and we hope to expand that by about 200 more, actually over the next 6 months or so. So that's it in a snapshot. Happy to take questions.
And I think a couple other partnerships that are important. We're DMH and the Sheriff's Department are integral members of the District Attorney's initiative on diversion. And so those are really important things that we're doing, trying to, in a safe way, divert your low-risk inmates out of the jail into community-based settings. So recidivism rate on the mentally ill runs about 70%. And it is the highest in the nation, whether it's LA County or California Department of Corrections. So we're working very hard to try to have better outcomes when we release them. So we're available to answer any questions you may have.
Yes, thank you so very much. And, I just want to mention, I really want to thank the Assistant Sheriff Terry McDonald for being here, because you are the one actually implementing and working on the ground on all of these things. So it's thank you so much for being here. And, and you stated earlier that you expect the consent decree to be over when the new jail gets built. Do you know what the timeline for construction, roughly?
Yes, so we have two different projects going on. One, we have the rebuilding, renovation of a women's facility up in Mariloma. So that's the first project. It should open probably in 3 to 4 years. Uh-huh. The other facility, probably 6 to 8 years, but we're trying to find a way to expedite at least the unit that houses the mentally ill so we can open that one sooner. It may be that DOJ, once we, if we've complied with everything else, once we break ground and it's clear we're going to build, they may let us off at that point because they'll realize the county's serious about it. Mm-hmm. But just saying we're going to do it is not going to meet DOJ's requirements.
Okay. And, the new jail is going to replace the men's central jail, the second jail, right?
Yes.
So right now, Twin Towers houses all the mentally ill jail clients. So the new jail is going to take that population over?
So how we're hoping it works is that we open the Mira Loma facility, and it's about 1,600 beds. It's a campus-style design for women. Campus-style design means that it's dorms, there's trees, there's grass, lots of programming space. Our plan is to move the women who are healthy up to Mira Loma from the Linwood facility. We have roughly 2,000 women in Linwood. The Linwood facility will become a men's medium security facility. Then we begin to tear down Men's Central Jail. We have a vacant jail up at Pitches called East. We'll reactivate that facility, move the women to Mira Loma, move men to CRDF, move men up to Pitches, tear down Men's Central Jail, and then build a two-towered system where Men's Central Jail is. Then we will begin to move our most acute mentally ill out of Twin Towers over to that facility. Now, one of our challenges is that we have projections showing the populations continuing to grow, and most alarmingly, it's the mental health, the medical, and the high security population that's growing. That's true across the United States. That's not unique to LA County. I suspect you'll ask Dr. Ortego why. It's crystal ballish, I think, but he can speak about that. So I think once we open the new facility, there will always be some level of mentally ill in Twin Towers, but the most acute mentally ill, and medicals, because remember, we also have very sick inmates who aren't mentally ill, who need treatment, and drug treatment and detox, because we don't currently have a good drug treatment or detox program in the jails.
So you're going to have a mental health, so at this point, you're probably going to have a mental health program both in the old Twin Towers and then, I guess, the new Twin Towers.
Yeah, it's a consolidated treatment facility, so it's the Correctional Consolidated Treatment Facility, CCTF.
Okay.
So the CCTF will be our primary, most acute treatment facility, but we'll continue to do treatment. We may actually have a small mental health program up at Pitches, right? Trying for your healthier mentally ill, not your acute.
Okay. I'm going to allow my colleagues to ask a few questions. I know you guys have a lot, but let me set the stage real quick and ask a few more. I think, Flora, you mentioned it. 10 years ago, when I was over there at the county, the jail systems and the mental health system were completely separate. So it's so exciting for all this collaboration. But you were mentioning that. Can you mention currently how the system is, who oversees the mental health in the jails, and then elaborate a little bit more on, you said going forward it's going to be the health department?
Okay. So currently, the Department of Mental Health is in the jail overseeing and administering the mental health treatment services. And along with, and Dr. Ortego heads up the actual mental health treatment. And then besides that component, we have jail linkage. And jail linkage then is not actually treating. They are assessing clients, coordinating, making placements out in the community. And so Department of Mental Health as a department is, there in the jail and also, of course, out in the community, which is where we're doing all of our work to place people, like in programs like the one Kathy has described. But moving forward, and we're in a transition phase right now, as part of the effort and, to integrate mental health, substance use services. It's a national push as well. It makes sense. It's a holistic approach to very complicated health issues. I'm actually a family nurse practitioner myself. So the board decided last year that the jail mental health services will be integrated in the jail with health, and because only about 20%, is that correct, Terry? About 20% of inmates are mentally ill. So you've got the other 80%. So, when we talk about healthcare, that covers everybody, or it's very exciting because until now, there hasn't really been a lot of substance abuse services, and now the Department of Public Health is also going to be, providing substance use services. But all of this will be under the umbrella of the Department of Health Services. So the Department of Mental Health, we are transitioning our staff, our programs over to the Department of Health Services. And that's good because all of that care will be coordinated now, integrated. And we will be, of course, still very involved with this population, but as I mentioned before, our emphasis will be as people are moving out into the community, that transition phase, and really scaling up some of our programs and working with public health for substance abuse and health for health services.
And Kathy, for linkages, if you could quickly summarize, because I know before here I worked for the second largest mental health hospital next to the jails, which was Kedron, and we had a pilot project with the Hilton Foundation grant, working with Molly Reisman, who now works for Supervisor Sheila Kuehl. I know there's a lot of linkages now, but can you describe, so we could tell our constituents, when someone gets released from jail who has especially a mental illness, I know our pilot project had a van picking them up, but can you kind of describe what happens, the actual?
So historically, unfortunately, a lot of people got released from the jail at inopportune moments, in the middle of the evening, so to speak, or in the middle of the night. But I think that has really changed over the last few years as we begin to partner and collaborate better and identify, that this person is accepting services in the community. I mentioned that we begin engaging that client while they're still incarcerated. And so if or when the client agrees to services, then we're ready to step in at the moment of release and to assure that they don't hopefully go back to the downtown area and recycle back and get reincarcerated quickly. So we have really focused on what clients need immediately upon release. They're not really big on needing therapy right away typically. What they like really is to assure that they have food, that they have shelter, that they have a place they can go and be safe. So our programs really address those sort of functional needs of the client and then hopefully establish enough rapport with the individual that once we have them stable, so to speak, we can begin doing sort of the therapeutic interventions that hopefully will address their recovery, which really may take several years.
So do you pick them up or?
Yes, we have the ability, the full service partnership teams, as I indicated, so each provider, it could be a Kedron, it could be a special services for groups, whatever the provider is, will actually go in, get the agreement of the client to transition from the jail into that community.
Before they even get released?
Absolutely, right. And so then we can be there, hopefully, at that moment to pick them up, take them, may have to go to a shelter, but move them towards housing right away and begin working with them over time.
And one last question, I don't know who could answer this, but substance abuse, the feds in the states changing a formula for that, and hopefully it will become like a full-service partnership parity for mental health. So the jails would be able to take advantage of that as well?
I'm glad you asked that question. So we have an agreement with the Department of Public Health. They've given us 50 community-based beds for women who serve, and they could have mental illness as long as it can be managed. They serve their sentences in a Medi-Cal-funded drug treatment facility today. Substance abuses, they're also coming in to do treating 800 inmates inside custody. But where we talk about mental health being a 20% problem, substance abuse is an 80% problem. And if you talk about the mentally ill, it's probably a 95% problem. So as we talk about what we're doing, I wouldn't want to leave here today and think 100% of the mentally ill are getting transported out, right? I mean, we're trying as best we can in a very strained system. So we are working on drawing down Medi-Cal dollars for substance abuse. We're also pushing and looking for advocacy on the IMD preclusion for mental health treatment. If you're not aware, and anybody can correct me, I'm going to do my layperson's version of this, is that we can't draw down Medi-Cal dollars for locked facilities if that facility is more than 16 beds. Those facilities don't exist, and they don't exist in a county like LA. So advocacy to try to push on the state and the federal government to allow us to draw down federal dollars for community-based mental health treatment is something that the city and the county would benefit from enormously.
And IMDs being the most severe patients and beds. I'm going to open it up to...
Thank you. If I can. Thank you, Mr. Chairman. And thank you, David, for bringing in our county partners. I think we need to recognize and celebrate this partnership between the city and the county. I mean, it's stronger than ever today. And I think it has a lot to do with your knowledge, David, of bringing in our county partners, even more so with the homelessness issue that's facing the city and the county alike. And to our Assistant Sheriff McDonald, thank you so much for making yourself available, and to this incredible panel here that's made yourself available. Thank you so much. Kind consent decrees, I had an opportunity through my years within the Los Angeles Police Department to be a part of a consent decree, a federal oversight that I felt has made the police department a stronger, a more effective, more accountable police department. And I know once the consent decree is over with the county jail system, it'll do the same as well. And to our Assistant Sheriff, how is the design going to be different than what's currently there today? Because I know you mentioned it in your earlier remarks.
So I'll try to describe Men's Central Jail. It's a linear design, which means if I'm an officer working a tier and you're my inmates, you're all in an individual cell, and to see you, I have to walk along a long row. So I cannot see the lady at the end when I'm looking here. And so it's not as safe for the staff, it's not as safe for the inmates. So we're going to go from that linear design to what's called direct supervision, which is it's designed in a way when I stand here, I can see every cell. Mm-hmm. So that's one of them. The other thing is Twin Towers is direct supervision. You can see in the cells. The problem is no treatment space. So when we're bringing inmates out for treatment to meet with the providers, it's happening in a day room where the cells are adjacent to it. And so the poor clinician's trying to maybe do an anger management class, and an inmate in the cell, in the second cell, is kicking the door or flooding, or somebody's trying to pass meds. So it'll go away from that old linear design to where we can see each cell, number one. And number two, it will be designed with appropriate treatment space for mental health clinicians as well as doctors to come in for specialty clinics. Now we're transporting inmates out to community facilities for treatments, whether it's an ortho or maybe a dermatology appointment. Now we'll have specialty clinics where we're bringing the inmate and the doctors into this area. It's safer for the community, it's cheaper, and it's more efficient. So kind of high level, how it'll look differently.
And even today, what we're seeing with our homeless population, a lot have suffered from both mental health issues as well as substance abuse issues. It's been my experience working the streets in the city of Los Angeles, and I'm happy to hear that you're capturing these individuals prior to getting released and building relationships with them. Ms. Warner, question for you on community providers, mental health community providers. How many do we have in the city of Los Angeles? Are you know?
We probably have about 125.
What's one of the largest community health?
One of the largest ones
in the
civic
city?
Clinics. Oh, in the city of Los Angeles.
Right.
So you mean downtown area?
It's just in the city, from Silmar to San Pedro downtown.
Oh, okay. So, well, you mentioned Kedron. We have Kedron, of course. We have special services for groups. We have Pacific Clinics. We have Inky. We have Mental Health America, if you know them. They go from the Antelope Valley all the way down to Service Area 8, which is the Long Beach South Bay area. Mm-hmm. So I'm mentioning adult providers.
Right. That's what I'm talking about.
So we also have, when I said there's a much larger number, we have providers that specialize in children and transition age youth as well.
And who's the overall regulatory agency that oversees? Is it the county and state, or both?
I'm sorry, I didn't hear
The
you.
overall regulatory agencies that make sure
County.
that...
These providers are under contract with Los Angeles County Department of Mental Health.
Are you familiar with the one in the Harbor area?
In which area?
Harbor area?
Harbor
Pacific
View
View, Harbor View, I believe it's the largest mental health.
Yes, I know that facility well. In fact, there was just an article, I think, in the paper.
Right, it's
yesterday.
been under scrutiny within the last couple months. It's been under scrutiny for years.
Well, it really was.
What part does the county play in holding them accountable and make sure that they're a good neighbor and to make sure that the individuals that they serve have the adequate service on site?
So if you know the history of that facility, that was a licensed residential care facility, probably the largest west of the Mississippi, I would suspect.
Right.
It's huge if you've been there and visited it.
As a police officer, many times.
Okay, and historically they were known to take people no one else would take, so they often do have a very difficult population that's been there. In the last several years, they did accept a contract with us for that level of care that I called field-capable clinical services. And truthfully, my staff are out there today having a meeting with them so that we can hold them more accountable to what our expectation is regarding what services those clients need. They are adjacent to one of my clinics called San Pedro Mental Health. We have tried to interface with that facility to both provide groups on site at that location,
Yeah.
as well as to have the residents there coming over to our clinic. So there's a lot of work that can be done. But they do have a mental health contract with us that we're now looking to make sure they're adhering to.
It's good to hear. I appreciate that. Maybe offline we can connect with our respective teams.
We can give you an update on the visit we're making today.
I'd appreciate that. In the shadows of Harbor View, we have numerous individuals sleeping on the sidewalks who suffer from both substance abuse and mental health. And, you know, they have an empty gymnasium that we feel they can take in a number of these individuals who are
Huge
living,
gymnasium.
right, that are living a former YMCA site, that are living on the sidewalks and in the streets that we feel can
So you're probably very aware of that homeless population.
Yes.
who's been-
especially in working with LASO, an incredible team, emergency response team that I have contracted out, and working with your team as well, the ME, the mental health department. So it's a great partnership, and I'd like to continue to work to build a stronger relationship with you and also the individuals who are running the facility there.
Absolutely.
And thank you, Mr. Chairman, for today.
Thank you, Mr. Chair. I want to thank all of you for coming in today and giving the presentation and for all your hard work on this. It's very clear that you have your arms around the issues, and it's very comforting to know. Questions in terms of, Flora, I think you mentioned the mental health linkage team. I think it was you. How large is that team? How many members?
Okay, so the mental health linkage team that's in jail, it's about 40, 42, you know, and that's not nearly the size that's going to be necessary under the consent decree, you know, to make sure more of the inmates are getting good, strong release planning. But the counterpart that's not in jail is really our court linkage team, and there's about 40, 42, 44 of them. And they are really the ones who are involved with, you know, the attorneys, DA, city attorney, the court system, to try to divert or have alternate sentencing for those individuals who are mentally ill, who really shouldn't, and, you know, it's not a safety issue and that should not be, you know, incarcerated. And many of them are homeless clients.
Do you have confidence that because of the consent decree that the county will come up with the funding for these linkage teams to be adequate in size and number?
Well, with the Board of Supervisors moving to establish, you know, they've established now the Office of Diversion and Reentry. When they approved that motion in late September, they also identified a significant new levels of funding for various components of the program. I mean, I was a deputy to former Supervisor Yaroslavsky for almost 10 years, and I've never seen this momentum of, you know, the whole board agreeing that we really need to address homelessness and the mentally ill population cycling in and out of jail. So it's not going to be enough because we're such a large county, but it's a great beginning and a great commitment.
Okay. And then in terms of the navigation teams, and I think it was you, Ms. Warner, that talked about the navigation teams and that it's a voluntary program?
Full Service Partnership is a voluntary program. There are some programs that have come forward subsequent to FSP, as we call it, like Adult Outpatient AOT, it's called, where you actually the consumer is court-ordered, so to speak, into outpatient services. That's just starting here in Los Angeles over the last 6 months or so.
And so this voluntary program, this FSP, is there a special focus on substance abuse and
Absolutely.
drug addiction and alcoholism, but it's voluntary?
It is.
That's a problem for me because people are going to choose to stay on their drugs and alcohol if given the choice.
Okay, well, I would say in terms of that one of the key work areas for our staff is really providing what we call evidence-based practices, cognitive behavioral therapy, really looking at with the individual what their behavior and that continued behavior pattern results in terms of their recidivism and quality of life. It does take time to do that.
I mean, I have no doubt that the people who choose to volunteer to go into the program, I have no doubt that it's a successful program. But I think just from what Mr. Buscaino said and my experience as well, and I was cheered to hear you, Sheriff McDonald, talk about 80% roughly being having some sort of substance abuse addiction. I would argue very strongly in the encampments that are in the 13th district, it's probably even higher. I mean, this is a population that is so incredibly resistant to assistance because of the addiction issues, and I think that's the crux of our problem. But I don't want to. I'm not here to be on a soapbox, but I'm cheered to learn about all these programs that the county has going to at least focus more on the issue, especially as it in relation to inmates. I think it's a real issue. And I didn't mean to cut you off. I'm sorry.
No, it's okay. And I'm just thinking of many of the clients that we see at the Women's Community Reintegration are court-ordered from probation to get a certain service in the community. I can't give you data off the top of my head about how many of them comply with that, but there are consequences if or when they don't apply. And certainly the partnership we're creating with Public Health now and Drug Medi-Cal coming forward, I think creates some opportunities for us. But I really support what you're saying. I understand it's a huge problem.
I think the court order piece is really critical for people who just are going to always choose not to get off of their substance addictions. And I don't have the answers for that, but I think we need to advocate for that as much as we can in terms of changing the law.
Yeah,
the courts, I'm sorry, Flora, the courts just opened 4 new collaborative courts for this type of event. You know, Prop 47, good example. The law was in the right place. The problem is, A, the funding's not going to come, and B, they're having a hard time figuring out how to compel people in treatment because compelled treatment does work. Now, it's important to understand if somebody's in acute mental health crises, it's not voluntary. Dr. Ortego's team will identify them and will move them under 5150 into a county hospital. But the conservatorship rules apply, and so many of the people that you're talking about, they're homeless, they're mentally ill, they've got substance abuse problems. Conservatorship doesn't work for
Plus,
them.
it's just a 3-day hold, isn't it? 5150?
Yeah, well, unless they need conservatorship.
They move towards conservatorship, you extend that hold.
But the state has gotten very liberal. The laws have gotten very liberal with conservative. So here we have people that we want to treat that are suffering, but they refuse. And then eventually they commit a nuisance crime.
Right.
And Dr. Ortego's got him back in the
That's right.
jail.
Well, and you mentioned the term compel as opposed to require. There's a huge, huge difference. And Prop 47 took away a critical requirement.
It's made it more challenging
yes.
for the courts, I think. Well, I think we'll work through it, but it's made it significantly more challenging.
And you also mentioned, I think it was you, Sheriff McDonald, 33,000 clients received help through the FSP, or it might have been you. I'm sorry. Are all of these 33,000 clients, are they considered in the low risk category?
No.
No.
No, I would not say they're
Is
all
that
low risk.
all categories?
Right.
Okay, I was just wondering about the clarification. And lastly, what percentage or portion of county mental health services budget comes from the MHSA, the Mental Health Services Act, monies?
That's a very good question. I mean, I guess I could find out for you.
It'd just be interesting to find out.
You know, when the economy was bad, I know we relied more heavily on the MHSA dollars. Our economy has bounced back. We have realignment dollars. We have other funding sources. I don't know if it's 50%, 40%, 30%. We could try to get you that.
And the reason I ask that is I am of the opinion that we need to sort of do a reboot of Prop 63 funding to actually produce bricks and mortar housing and wraparound services for the mentally challenged, mentally ill individuals. So me feeling that way, I want to make sure I don't get ahead of myself and then start advocating for underfunding what you're doing at the same time. I mean, we have to sort of all hands on deck figure this out and get in the production of more housing. If we could...
I'd be happy to meet with you about that.
Okay, that'd be terrific.
But I think we really support, and there's a lot of energy around looking statewide at our MHSA dollars and where those dollars have not been fully expended, and maybe taking some of those dollars to privilege the needs for the homeless populations and do the brick and mortar that you're talking about. I do feel that may be in our future, so to speak.
Terrific. Yes,
So
Laura.
actually, the Board of Supervisors right now this morning has an item on the agenda specifically to look at the proposed legislation to move a certain amount of MHSA funding into capital dollars. And I think they're looking at about $40 million for from LA to be moved into that
Terrific.
category. So I think it is really important not to undermine, though. I think, it's good to relook at MHSA, how it's
But as you said,
allocated.
not undermine
Yeah.
all this other great work as well. And that's why I was going there. It's like we need to make sure that when we advocate for things that we don't
Right.
have, the unintended consequences of
We don't
undermining
want a
good
situation
programs.
where we have to lay off staff or.
Exactly. Nor would I. So I like the fact that the county board of supervisors has said we're going to get to 100 million. Los Angeles city leadership says we're going to get to 100 million as well. So that's all good. So it's a matter of how we get there and how we allocate the resources.
Yeah, and in reality, above and beyond the 100 million, Department of Mental Health has put in, more than 100 million of our resources into this. So it's good that more and more funding is being identified. It's looking for the different sources. And we also, as the department, have applied for several different federal grants on reentry planning that are going to be implemented this year and next year, from federal level. And so we're busy looking, as Terry does, for every type of funding possible.
Terrific. Well, thank you so much. And I think that the work that you all are doing helps provide the building blocks and a strong narrative that we have professionals really doing the groundwork and in the trenches so that I think residents, citizens, the population will have a lot more confidence that we're not just throwing money, looking for money to throw around at the problem, but really putting it into good use.
Absolutely.
Thank you.
And and this is a very passionate topic for all of us, and I'm really bad on time. But just to let you know, the Mental Health Services Act is about $1.8 billion collected statewide now.
Yes.
It's about 1.8. I don't remember the new numbers now, but probably after leveraging that the county could do, it's probably about $1 billion that comes from Mental Health Services Act. And the leaders on that, the reboot needs to happen at the state, and I believe Senator Pro Temp Kevin DeLeon with Darrell Steinberg.
Yes, I'm aware of that. I had a long conversation with Darrell Steinberg in early November about this subject. If the state isn't able to act, the county can. That's the good part.
Right. And the motion that the board is entertaining this morning, perhaps they've already adopted it, actually directs the CEO and the Department of Mental Health to look at the upsides and the downsides and how it would impact. So.
Sounds great.
Right. And thank you, Councilman Briscano. When I first got here, I know a lot of the council members are contracting on our own with a lot of these nonprofit providers, which was a frustration of mine. And one of my goals, and I've been having a lot of offline conversations with the county, is re-leveraging these resources, because the city is we're supposed to get these services already, because the city is one of 88 cities in the county. So these are the things that we're trying to go towards and collaborate. And I think the key point is we can't do it alone. And one thing I want to ask is, and I'm sure my colleagues would agree, I visited Twin Towers and Men's Central Dale 12 years ago, and a lot have changed, and I'd love to see everything that's going on. Could we possibly maybe do a visit?
I was going to close with, I invite you to come out and tour with
Great.
us.
So I will work with my
Definitely.
colleagues, and
Love to.
so because you have to see it, and you could actually put it. Well, thank you so very much for
Thank
coming.
you.
And
Thank you.
We'll be in touch
Pleasure to
with
meet
you. And we're running. Public comment. I have one comment card for item number 1, which is Wayne. 1 minute. He's gone. Okay, great. Item number 2. Well, I'm sorry. I'd like to move this item. Next up. Where am I?
Approve the motion.
Yeah, approve the motion. So moved.
Yep.
Item number 2. Mr. CLA, could you read it into item agenda number 2?
Item number 2 is motion Rue O'Farrell relative to request to the Personnel Department to report on the status of any current citywide health, safety, and wellness plans that reduce workforce injuries, improve recovery times, and keep city employees healthy, as well as recommendations for implementing any new plans which may be needed.
Great, thank you. Can the representatives from the Personnel Department and the Mayor's Office come forward? And I apologize. If my colleagues need to go, I could take this as a chair's item, as a report, but this is a very important issue, wellness, and this is something that my office has been very interested in. But, so whenever you guys have to go, I'll release you guys, and we could take it as a chair's item. Thank you so much.
Thank you, and we will, in the interest of time, of course, keep our remarks as brief as possible. I'm Wendy Macy, General Manager of the Personnel Department. With me is Greg.
Oh, and can you, if you could give the copy of your presentation in case my colleagues leave, and I'll make sure you guys all get it.
Thanks.
Certainly, is Greg Dion, our Assistant General Manager, as well as Adam Bierman and Mark Anthony Thomas from the Mayor's Innovation Operation Team. As you know, this is a workers' comp and our employee health and wellness has been a big issue for our council. I just want to highlight a few sort of eye-opening numbers. We do get about 7,100 new claims a year. We have 14,500 open workers' comp claims, and our annual costs related to workers' compensation is above $228 million. So it's definitely a big issue for the city. I also want to note that of the new claims, about 93% actually come from the top 10 departments. And so we've been focusing a lot of our attention on administering those claims and working with those departments, getting people back to work quickly. But we've also had a great partnership with the mayor's office and have been providing them data over the last 6 months. And they've been doing a deep dive analysis into how can we actually be more preventative and proactive in addressing workers' compensation claims and healthcare costs. And that's doing some very important initiatives with respect to employee safety as well as employee wellness. Those of you who know me know that wellness is a big passion of mine, and that our Joint Labor Management Benefits Committee has also asked us to come forward with a proposal for a wellness implementation plan that we're going to bring to the Personnel and Animal Welfare Committee shortly. And that is an exciting initiative which will leverage money that is available to us from our providers such as Blue Shield, but we also do need city staffing to implement a program so that we can proactively address employee wellness. So I'm going to turn it over to Adam and Mark at this point, and they have a slide deck.
Great, thank you very much. Good morning, council members. We'll get through our presentation as quick as we can. I think we've done it in about 8 minutes, so see if we can beat that time. First, I want to thank personnel. They've been amazing partners, and I don't think we could have done any of the work that we've done without their help and their collaboration. So my name is Adam Bierman, and I'm on the Operations Innovation Team in the Mayor's Office, and I'm the project lead for our Wellness and Safety Initiative. Our presentation goes over some of our findings and our preliminary initiatives that we're looking at, but before we get to that, I just want to note that what this really comes down to is valuing our workforce, which is our city's most valuable asset. And at the core, it comes down to how we as a city prioritize our workers. So with that, I started about 4 months ago, and after a couple weeks of just internal study and getting up to speed, I set out to meet with as many people in the city as I could. General managers, safety engineers, risk managers, and regular employees to understand their perspective and to try to wrap my head around what works well in the city, what doesn't, what our big challenges are, and what it looks like across different departments. And then, as I mentioned, I've partnered closely with personnel and with the city attorney's office to work on these reforms. And at the same time, we've done outreach with other big cities to find out how they do compared to us, what they're doing, kind of information sharing. And then finally, we've reached out to some of the experts in the private sector at the state and federal levels. So internally, we've been mapping out what the processes and operations look like in the city. So for example, we studied the life cycle of an injury claim from what the city's doing to prevent injury all the way through to returning an injured worker back to work as quickly as possible. And then we've mapped out the roles and responsibilities throughout the city to understand where there may be gaps or where things can be synced up, and trying to wrap our head around everything that the city does in this field. Essentially, the scope of the problem is that we use our workers' compensation system reactively to address injury in the workplace, and our efforts to prevent injury in the first place are insufficient. These challenges have been the focus of a number of city controller audits recently, as well as media coverage. And the breakdowns that the effects of these breakdowns are tremendous on our city. So as Wendy mentioned, last year, 18% of our workforce filed an injury claim, which is over 7,000 injury claims, costing at least $223 million last year and over $1 billion over the past 5 years. So that's a significant amount for our city budget. That's 2.5% of our annual budget, and that those costs alone are more than 33 of the 37 budgetary departments' budgets. When we look at our injury claim rate, it's 18 claims per 100 employees, and sworn rates are very high in police and fire, 32 and 36. But it's not just a sworn problem. Civilian departments are also high. The Department of Transportation is at 20 claims per 100 employees. And when we look at how that compares to other cities, nationally we compare very unfavorably. But if we want to do a more apples-to-apples comparison of cities with similar risk profiles subject to similar state law, we see that we still compare relatively unfavorably. And as I mentioned, these costs are large and growing. They're up from $150 million 10 years ago, and at this same rate will be $300 million in 10 years. Most importantly, I think the high claims rate affects our ability to attract, develop, and retain the best for our workforce. And it's really the heart of the city. I've met with folks, and the workforce really drives this city forward, and these claims rates and the effects of these claim rates, and there are a lot of effects that come with people being out all the time, really has an impact on our workforce. So our big vision is to make Los Angeles the safest city to work for. We deserve to be an industry leader in employee wellness and safety. So we want to permanently reduce injury rates and related costs across all departments, and put metrics and data tracking at the core of our safety and wellness efforts to assure accountability and to assure that this stuff's actually working. So, do you want to speak to this?
Yeah, and in general, the Mayor's Operations Innovation Team is actually created through a public-private partnership with the Mayor's Office and the LA Coalition for the Economy and Jobs. And we really join a subset of other innovation-driven approaches where, in our case, we're actually looking inside the city to see how we operate and work collaboratively with the council, with the departments to really fix some of these longstanding challenges. And so we are following what we see as a proven track record of innovation delivery that really moves from priority initiatives to actual reform, but we want to work pretty closely with the council staff, with the departments, with elected officials to make sure we actually can have a collective impact and buy-in.
So our priority areas and initiatives fall into 3 buckets. And in the interest of time, I'll just give a very brief example of one of the initiatives from each bucket. As Mark mentioned, over the next 3 months, we're going to be working with all the stakeholders to vet these ideas and build out exactly what they look like, obviously with buy-in from departments and other stakeholders and their input as well. I'd also note that we wouldn't be able to do any of this if it weren't for the collaboration with city departments, with folks who are on the ground. They know it a lot better than we know it on a day-to-day basis, and so we really rely on their perspective. So our first area is expanding our information sharing and performance metrics. There's a lot more that we could be doing with respect to our data collection, analysis, and reporting. If we have a comprehensive effort to improve safety and wellness, it's going to require our data systems are up to best practices. The city's been considering a risk management information system and we want to help to facilitate the development of that system and assure alignment across our current systems. Our second area is our injury prevention and response programming, and so this is, the city does not currently have a wellness program. If you look in the private sector, these have become ordinary course. And if you look at studies, healthier employees get injured less often and stay out for shorter periods of time when they are injured. We've been working closely with personnel, and they've actually secured funds from our healthcare providers for the development of a wellness program. So we just need to implement that program and build it into our city. And I think that would help a lot. And then thirdly, we want to have accountability and oversight. So we've got a few different ideas, but we've been working with the city attorney's office and the risk management folks in the city attorney's office to reconvene the risk management steering committee, which would be a body that can really hold departments accountable, have city leadership on it, and develop a citywide strategy for risk management. And in this initiative, we're also going to be looking at other forms of risk management leadership. How do you have a large decentralized entity, and how do you control its risks? So our next steps, as Mark mentioned, we're going to collaborate with the City Council, other elected officials, and departments to build out our reform plans. We're going to re-engage and engage our experts to map out success and determine what best practices are. We'll ensure adequate research for decision making, and then finally assign long-term placement of roles and responsibilities to ensure that this is a permanent solution to reduce our injury costs and injury rates. So at this time, take any questions.
Terrific. Mr. Chair, I'm going to take off, but I just want to say I'll lead anyone on a fitness and training sort of course. I'll directly participate in this. I have to go downstairs. Thank you, though.
Sure.
Okay,
Thank you.
Thank you. I'll take this as a chair's report, and this is very important. I mean, based on your potential cost savings, this could generate the $100 million that we need to solve to contribute to the homeless problem. So, so if you could, this updated presentation, if you could forward, Mr. CLA, if you could make sure all the members get a copy of this, and if you guys could also provide either on a separate one or you could add it to the presentation, what percentage of the injuries are estimated to be fraudulent, and you highlighted some of the main departments that are drivers in the claims. If you could kind of give us a more focused breakdown on that. And let me see. Where is it? Metrics on the current programs. The current programs that you guys have for employee health and injury reduction, and what metrics you track. So if you could do it on a separate document, and if you could get it to the CLA so you could get it to all of the members. And I guess it's automatically continued since I don't have a quorum, right?
Well, since you don't have a quorum, the meeting is no longer,
Right.
and
So
so
I can't
you can choose to continue the item if that's what you would like to do.
Yeah. So when we do have quorum, at our next meeting, I am going to ask that you guys continue this and report back to us with your recommendations, working with all the other departments. So if you could get that information to us, and we'll work with the personnel department and reschedule it at a later time for updates.
Sounds
But thank you so very much.
Thank you for your time.
thank you.
Fully support of everything that you're doing. We need to do this. Thanks.
Thank you.
And meeting's adjourned.